Okay, so this gets us to the next question, that is question 141. The degradation of intracellular organelles through the process of autosomes with autophagolysosomes, it is called as autophagy. It is called as autophagy. The name tells you everything. It is autophagy. The degradation of intracellular organelles, it is taking place by autophagolysosome formation. Autophagy. Nothing to explain. Next point, question 142. Question 142. The most common primary tumor in the heart is myxoma. Answer is D. That is, the most common primary tumor in the heart is myxoma. First point, most common heart tumor, most common tumors in heart, they are metastasis. Most common tumors in heart, metastasis. From where are they coming? They are coming either from lungs, metastasis from lungs and breast. Lungs and breast. These are the most common sites of metastasis. Next point, most common primary tumor of the heart, it is myxoma. This, it is present in left atrium. This is present in left atrium. Plain and simple. Next point. Coming to the next question, question 143. Question 143, which is not a feature of non-cirrhotic portal fibrosis. Bridging fibrosis, not a feature of NCPF, is bridging fibrosis. So the name tells you everything. Non-cirrhotic portal fibrosis. Non-cirrhotic matlab cirrhosis is not seen. So if cirrhosis is not seen, bridging fibrosis would not be seen. So in this case, jaundice is absent. In NCPF, jaundice is absent. Age group, young adults. Age group, young adults. Most common symptom, GI hemorrhage. So age group, young adults, most common symptom, GI hemorrhage. Next, the other features, thrombosis and non-specific inflammation, they are true, but bridging fibrosis is not seen. Next, question 144. Question 144. All these, they are easy questions. Having an unaffected baby when both have achondroplasia. Answer is 25%. B, that is 25%. Why? Because achondroplasia, it is autosomal dominant. It is autosomal dominant in nature. So when both the parents have achondroplasia, it means both have their autosomal dominant, so one gene is abnormal. Suppose abnormal gene is capital A. So when the kids occur, AA, and AA, what is the chance of having a normal baby? 25%. Autosomal dominant, the chance of having a normal baby is 25%. Next point. Coming to the next question, that is question 145. Question 145. CDK associated with cyclin D is CDK4. CDK associated with cyclin D, CDK4. Now let us see few points with cyclin D. Cyclin D It is responsible for progression of the cell cycle. It is responsible for progression of cell cycle at G2M checkpoint. I'm so sorry, at G1S checkpoint. It is responsible for progression of the cell cycle at G1S checkpoint. How? By binding with CDK 4 and 6. By binding with CDK 4 and 6. So here CDK 6 is not in the options. So answer is CDK 4. Next point. Question 140. This was question 146. CDK 4. Next question 147. Question number 147. Now, grading and staging of chronic hepatitis is done by necroinflammatory grading systems. Necroinflammatory grading system. This is used for grading and staging of chronic hepatitis. This is the best answer. Now, there are two necroinflammatory grading systems. The most commonly used necroinflammatory grading system is Nodal's Hepatitis Activity Index. Most commonly used, Nodal's Hepatitis Activity Index. This is the most common grading system, whereas more extensive is the European Metaware system. More extensive is the European Metaware system. So the best answer, that is grading and staging, is done by necroinflammatory grading system. Next, question 148. Question 148. SGOT to PT less than 2 is seen in all except alcoholic hepatitis. Alcoholic hepatitis. This point is important. In alcoholic hepatitis, AST to ALT ratio of 3 to 4 is to 1 is seen, and this AST to ALT ratio, it has a special name to it called as de-Ritis ratio. In alcoholic hepatitis, this ratio of 3 to 4 is to 1 is seen in alcoholic liver disease and has a special name, de-Ritis ratio. So it is less than 2 in all except alcoholic hepatitis, because in alcohol this SGOT to SGPT ratio, it is 3 to 4 is to 1. Next, question 149. Okay. Question 149. Morbidly obese 51 dies of complications. Her heart is massively enlarged. Beneath the epicardium, adipocytes are entering into it. So the answer to the question is fatty infiltration. The fat cells, they are entering into the heart cells. They are seen in the interstitium between myocardial fibers. It is not cholesterolosis, it's not gallbladder, no steatosis. Steatosis is intracytoplasmic accumulation. It is not intracytoplasmic, and steatosis is a term that is used with liver. This is taking place in heart. So fatty infiltration. Next, question 150. Typical appearance of granulation tissue is due to budding ends of capillaries. It is due to budding ends of capillaries. That is why granulation tissue, it is pink, soft, granular in appearance. It is a pink, soft, granular tissue in appearance because of budding ends of capillaries. It is showing angiogenesis. Next, question 151. We have already seen this. Dystrophic calcification occurs in dead tissues. So, rheumatic heart disease is okay, lymph node involvement, that's okay, aneurysms, it will show dystrophic calcification. Where it will not be seen would be normal kidney. Normal tissues show metastatic calcification. Dystrophic calcification, dead tissues. We have seen this table earlier. Next, question 152. Dark granulomas, they are seen in brain. Dark granulomas, they are seen in brain in cerebral malaria. This has to be remembered. Dark granulomas, brain, cerebral malaria. Next, CD99. We again have seen this question earlier. Remember when we were doing the various markers, stem cell markers, CD34, CD99. Then we saw CD99, it is also positive in Ewing sarcoma, and the most common translocation with Ewing's was translocation X18. We have seen this earlier. So CD99, it is a marker of Ewing's sarcoma. It is a marker of Ewing's sarcoma. Next point, question 154. Smudge cells are seen in CLL. They are seen in chronic lymphocytic leukemia, that is CLL. Another 3-4 questions, they come from CLL, that is CLL. It is a B cell tumor, firstly, which is CD5 positive, CD23 positive. This is important. Peripheral smear shows the presence of mature appearing lymphocytes. Peripheral smear. So let's start again. CLL, it is a B cell tumor, CD5 positive, CD23 positive B cells. Peripheral smear shows a high TLC, high total leukocyte count with mature appearing lymphocytes, along with the presence of smudge cells. Next, question 155. Question 155. We have again seen this earlier. HMB45, it is a marker of melanoma. HMB45, it is a marker of melanoma. When we drew the list of various markers, we have seen this. Next point, question 156. This is a factual question which is non-specific esterase. It is, remember when we wrote the stains, monocytic M4, M5. M3 can also show NSC, whereas it is not seen in AML M6. So the answer is D, that is AML M6. What is AML M6? It is acute erythroleukemia. It is acute erythroleukemia. How did we come to know that it is erythroleukemia? It is positive for glycophorin A, CD36 and CD71. Erythroleukemia, positive for glycophorin A, CD36 and CD71. Next, question 157. Peutz-Jeghers syndrome is not associated with ampullary carcinoma. It is not associated with ampullary carcinoma. Intersusceptions, oral melanotic, that is black patches around mucosa, cutaneous pigmentation and carcinomas of pancreas, they are seen, but what is not seen is ampullary carcinoma. Next, question 158. Question 158. Translocation 1221. Translocation 1221. It is seen with TEL AML. TEL AML. So let us see the points with translocation 1221. It is seen in BALL. It is seen in BALL associated with a good prognosis. Associated with a good prognosis. And the fusion transcript in this is TEL AML. Fusion transcript TEL AML. You very well know BCR ABL. This is translocation 922. Translocation 922. PML rara. PML rara. This is translocation 1517. We have already seen the details with PML rara seen in M3. This we have already seen. Next point. Question number 159. Question 159. In a patient, the electrophoretic mobility of HBS compared to HBA is retarded. It is retarded. See, what we see normally, if this is the point of application, close to the point of application, we have a band of HbA2. Close to the point of application, there is a band of HbA2. Then there is a band of HbS. We are talking about a patient of sickle cell trait. We are talking about sickle cell trait. HbA2. Next, there is a band of HbS. Next, there is HbF. And last is HbA. This is what we see on gel electrophoresis. This is what we see on gel electrophoresis of hemoglobin. So this is hemoglobin electrophoresis, and this is the migration. Point of application, first HbA2 comes, then HbS, HbF, HbA. So what is the mobility of HbS compared to HbA? This is closer to the point of application. So this is retarded. This is retarded. Next, question 160. 160. Enamel-like suprastructures. This has to be remembered. It is seen in craniopharyngioma. Craniopharyngioma. So, what is craniopharyngioma? It is a hypothalamic suprasellar tumor. Craniopharyngioma. It is a hypothalamic suprasellar tumor. It is a tumor in above the cellar area. Hypothalamic suprasellar tumor, derived from remnants of Rathke's pouch, derived from remnants of Rathke's pouch. It is a hypothalamic suprasellar tumor derived from remnants of Rathke's pouch. Most common site is near optic chiasma. Most common site is near optic chiasma, and it is associated with enamel-like suprastructures. So answer is craniopharyngioma. Next, question 161. Subepithelial deposits with spikes are seen in MGN, membranous glomerulonephritis. MGN, the deposit, has a special name to it called as spikes, whereas PSGN, it has a special name called as humps. So spikes in MGN, humps in PSGN. Easy. Next, question 162. All these are the one-liners, nothing to be explained in that. Warm antibodies, autoantibodies are seen in SLE. Warm autoantibodies are seen in SLE, whereas cold autoantibodies, they are seen with Mycoplasma pneumoniae infection. Mycoplasma pneumoniae infection. This is asked. Autoimmune hemolytic anemia, warm type associated with SLE, cold type with Mycoplasma pneumoniae. Test for autoimmune hemolytic anemia, Coombs test. Test for autoimmune hemolytic anemia, we do the Coombs test. Done. Next point. Question 163. Question 163. Which of the following is most likely to be associated with megaloblastic? Other levels are normal, so answer is atrophic gastritis. Answer is atrophic gastritis. This again is obvious because in atrophic gastritis, HCl secretion and intrinsic factor secretion reduces, as a result of which intrinsic factor reduces, as a result of which it is associated with the development of pernicious anemia. So vitamin B12 deficiency, others are normal, atrophic gastritis. Next, question 164. Chronic graft rejection. This is actually a repeat and we have already seen this. Chronic graft rejection, we have seen this earlier. It is type 4 hypersensitivity. Chronic graft rejection, type 4 hypersensitivity. We made a table of the types of graft rejection earlier. It is type 4 hypersensitivity reaction. Next point. Question 165. This is important. Tennis racket cells are seen in rhabdomyosarcoma. Tennis racket cells are seen in rhabdomyosarcoma, whereas tennis racket granules or tennis racket cell or tennis racket appearance is seen in, you very well know this, and this again has been asked repeatedly, it is seen in Burbach granules or Langerhans cell histiocytosis. Burbach granules, they give the classical tennis racket appearance on electron microscopy in Langerhans cell histiocytosis. In Langerhans cell histiocytosis. So tennis racket cells in rhabdomyosarcoma, tennis racket appearance, that is Burback granules, and on electron microscopy seen in Langerhans cell histiocytosis. Next point. Question 166. Pale infarct is seen in all except lungs. So, liver, spleen and kidney shows a pale infarct, whereas lungs show a red infarct. Lungs show the presence of a red infarct. This has to be remembered. Next, question 167. We unfortunately again have seen this. Chemotaxis. Is it random or is it unidirectional? It is unidirectional. Chemotaxis is unidirectional, and we have even made a list of chemotactic agents, endogenous, exogenous. The main endogenous chemotactic agents are C5A, most potent leukotriene B4. Most potent leukotriene B4. Next, question 168. Question 168. HLA B27. This is asked. It is associated with ankylosing spondylitis, psoriatic arthritis, Rita's disease. So the answer is all. You can add one more to this. It is also seen in reactive arthritis. So HLA B27, it is seen in everything: ankylosing spondylitis, psoriatic arthritis and Rita's disease. Next, question 169. Patient with achlorhydria, that is HCl is reduced, undergoes Schilling test, which is typically seen in pernicious anemia with gastric atrophy. The answer is C. See, what is happening in answer C is B12 is not detected in urine. It would not be detected in urine because patient has pernicious anemia, reduced intrinsic factor, so vitamin B12 it is not getting absorbed, so B12 is not detected in urine, but it is detected in urine after we supplement with oral intrinsic factor. After giving oral intrinsic factor, B12 starts getting absorbed from the food, so now it would be detected in urine. Hence the answer is C. That is, it is not detected earlier but is detected after oral therapy with intrinsic factor. Next, question 170. Which of the following is an exudate? It is empyema. Nothing to be told in this. You know the difference between exudate and exudate. You know that empyema, it is purulent in nature, so it is an exudate. Next, fleshy soft lymphatic infiltration, it is PUD orange. This is an easy surgery based question, that is PUD orange. PUD orange. Question 171. Next, question 172. Question 172. Pass positive Whipple's disease. Extremely important. Extremely important. Whipple's disease, it shows the presence of Pass positive diastase resistant granules. Whipple's, it shows the presence of Pass positive diastase resistant granules. कहाँ पे? In macrophages. In macrophages. And it has a diagnostic biopsy with the diagnostic feature being pass positive diastase resistant granules in macrophages. Next point, coming to question 173. Coming to question 173. Pincered spherocytes. Now see the difference. Most common defect in hereditary spherocytosis, we know it is enkydin. Most severe, spectrin. We have already seen this. Whereas pincered spherocytes, they are because of B and band 3. So the pincered spherocytes, they are formed because of a defect in band 3, which is wrongly written in your paper as B and 3. It is band 3, pincered spherocytes. Next point, question 174. Question 174. Indian childhood cirrhosis, it is characterized by inflammation, Miller-Line bodies and fibrosis. What it is not showing is fatty change. What is not seen in Indian childhood cirrhosis is fatty change. This disease, it carries a high mortality. Indian childhood cirrhosis, it has a high mortality. Microscopically, it shows pericellular fibrosis with neutrophils. There is presence of neutrophils and fibrosis is present, but fatty change is not seen. There is also huge amounts of copper which is seen in this disease. Copper is also present. Next, question 175. Question 175. Nanoscale cantilever array. This is a biomarker of cancer cells. This has to be remembered. It is a biomarker of cancer cells. To nanoscale cantilever, it's an upcoming marker for cancer cells. Next, 176. Lymph node metastasis. It is commonly seen in rhabdomyosarcoma. It is commonly seen in rhabdomyosarcoma. This is again a factual question. Lymph node metastasis, rhabdomyosarcoma. Next point, question 177. Question number 177. What does the term cardiac polyp mean? Cardiac polyp, it is a fibrinous clot. Cardiac polyp, please note, it is not a polyp per se, it is a fibrinous clot which is forming in the heart when red cells sediment before blood coagulation. This is formed when the red cells, they sediment before blood coagulation, in turn leading to the formation of a clot. This is chicken fat layer with a upper chicken fat layer, with the presence of an upper chicken fat layer. This is cardiac polyp. Next point, large cells, they are seen in neonatal hepatitis. Large giant cells. These are the factual questions, nothing to be explained in it. Neonatal hepatitis, large giant cells. Next, test to differentiate maternal blood from fetal. Kluwer-Betke test. Kluwer Kluwer-Betke test. Point to be noted here is Kluwer-Betke test. It is a quantitative test. So this is a better answer. This is a better answer than apt test, which is a qualitative test. Kluwer-Betke, this is a better answer than apt test, which is a qualitative test. Next point, Paneth cells. Paneth cells. This again is a factual question. They have numerous lysozyme granules. Paneth cells have numerous lysozyme granules. Whereas sister Mary Joseph nodules, they are seen in gastric carcinomas. You very well know what are sister Mary Joseph nodules. They are palpable nodule bulging in the umbilicus. Sister Mary Joseph nodule, it is a palpable nodule near umbilicus. Palpable nodule near umbilicus, and most commonly associated with gastric cancer and colonic cancer. Most commonly associated with gastric cancer and colonic cancer. Sister Mary Joseph nodules. Next point, multifocal tumor of vascular origin in AIDS patient. 182, Kaposi sarcoma. Easy. Question 182, Kaposi sarcoma. That is option A. Question number 182. So they develop in patients of HIV and organ transplant. So Kaposi sarcoma, it is seen in HIV and lymph node involvement, and in this they can develop in any stage of HIV. Next point, it is associated with HHV8. This is the next important point. It is associated with human herpes virus 8. HHV8, that is human herpes virus 8. Next, we have already seen this. Rosettes are seen in retinoblastoma. When we were discussing the rosettes earlier, we have seen neuroblastomas, retinoblastomas. They show the presence of rosettes. What are rosettes? They are circle of cells which are seen microscopically. Next point, PIC bodies. PIC bodies stain positive for ubiquitin, tau proteins and LZ50. What they do not stain for is alpha-synuclein. What they do not stain positive for is alpha-synuclein. They are positive for ubiquitin, tau and LZ, not alpha-synuclein. Next, 185, which of them is benign? Gardner's associated with familial adenomatous polyposis, it is malignant. Turcot's again associated with FAP, it is malignant. FAP, familial adenomatous polyposis, is malignant. So the answer is juvenile polyposis. So the answer is juvenile polyposis. Next, acridine orange is a stain for, all of you know this, DNA and RNA. DNA and RNA. Next, not used to stain fats. 187, it is B, Congo red, because you know Congo red is for amyloid. Congo red, it is for amyloid. So the next question that is asked is, what is the color with Congo red? It gives it a brick red color, or a better word is color of amyloid with Congo red, salmon red color. This is on light microscopy. This is on light microscopy. Apple green. Apple green is the birefringence that we see under Congo red for amyloid. Apple green is the birefringence. Next, question 188. So Congo red, light microscopy, salmon red color. Apple green is the birefringence under polarized light. Next, all are labile. Labile matlab they are able to proliferate numerous number of times. Intestinal cells, they do. Kupffer cells are the macrophages, they do. Keratinocytes, skin cells, they do. Answer is hepatocytes. Hepatocytes, they are not labile in nature. So answer is hepatocytes. Next, point mutation. You very well know this. 189, sickle cell anemia. Nothing to be explained. It is a point mutation, as a result of which glutamic acid is replaced by valine. Sickle cell anemia. It is a point mutation, as a result of which glutamic acid is replaced by valine in the 6th codon of beta chain. In the 6th codon of the beta chain. Next, question 190. Ulcerative colitis, skin lesion associated with it, pyoderma gangrenosum. This is again a factual question. Pyoderma gangrenosum, the skin lesion associated with ulcerative colitis, pyoderma gangrenosum. Next, 191. Chronic ITP is due to, ITP stands for immune thrombocytopenic purpura. So the name tells you it is immune in nature. So it has antibodies against platelets. Immune thrombocytopenic purpura. So it is associated with the presence of antibodies against platelets. And in ITP, the antibodies are against GP1B9 complex and GP2B3A complex. So in ITP, the antibodies are against GP1B9 and GP2B3A complex. Next, question 192. This is vinyl chloride. This has to be remembered. It is implicated with angiosarcoma of the liver. This is implicated in angiosarcoma of liver. We saw this with NCPF also. So, angiosarcoma of liver. Next, 194. Markers in bucket cells. Buckets, it is a mature B cell neoplasm. Buckets, it is a mature B cell neoplasm. So it is CD34 negative, surface IgM positive. That is your option C. It is CD34 negative, surface IgM positive. Mature hai, 34 is a stem cell marker, so it is 34 negative, surface IgM positive. Next, basement membrane. Let it be ocular or let it be any other basement membrane. It is stained by PAS, periodic acid Schiff. It is stained by PAS, that is periodic acid Schiff. Next point. Question 196, which is fairly specific for ventricular dilatation, BNP. Ventricular dilatation in congestive heart failure, B-type natriuretic peptide. You will be doing this in detail in physio. BNP or B-type natriuretic peptide, it is secreted by ventricles in the heart. It is secreted by ventricles in the heart. Next, the release of BNP, it is modulated by calcium channels. The release of BNP, it is modulated by calcium ions. Next point, early granulation tissue formation. You will be doing this in detail in physio. Next, early granulation tissue formation. We have already seen this. It is done at 1 week. We had made a whole pattern of changes. We did a whole pattern of changes with MI. So by mistake I skipped question 193. These two questions we are doing them together because they are related to MI. We have seen the pattern of changes. So 193. Early MI is most likely to reveal option C, that is coagulative necrosis with granulation tissue. See, please don't get confused in question 193. Edema in between myofibers, that is half an hour to 4 hours, too early. Necrotic with neutrophils is 1 to 3 days, but most commonly what we see is either coagulative necrosis or granulation tissue. So out of the options that is given in the question, the most likely to reveal pattern, I know they are with respect to the time periods, but most likely to reveal is C, that is coagulative necrosis with granulation tissue. Next point, coming to question 198. This is again a factual question. CNS AIDS. Question 198. CNS in AIDS shows microglial nodule. This has to be remembered. Next important point is in AIDS, in CNS in AIDS, vasculitis is not seen. This has been asked as a written MCQ also. Vasculitis, it is not a feature of CNS and AIDS. Next point, question 199. Migratory thrombophlebitis is seen in all except prostate cancer. Lung cancer, pancreatic cancer, GI cancers, lung, pancreas, GIT, they show migratory thrombophlebitis but not prostate cancer. Last point, question 200. Question 200. Massive splenomegaly, it is seen in CML, it is seen in PCV, that is polycythemia vera, and it is also seen in primary myelofibrosis. Where it is not seen is primary thrombocytosis. It is not seen in primary thrombocytosis. It is just associated with mild splenomegaly. Mild splenomegaly. Done. So this finishes your pathology paper, and in case you have any doubts whatsoever, my name is Sushant Soni, so you can email to me at sushantsoni@gmail.com. Any query or whatsoever you have, you can email it to me at sushantsoni@gmail.com. Done. Thank you.